Okay, now we're going to head into Chapter 7. We're still talking about somatosensation. This chapter is labeled with the subtitle of Clinical Application. So there are a couple of two chapter sequences in this book. One of them is the cerebrum, and then it has cerebrum clinical applications. And this one, somatosensation and clinical applications. So we're going to talk more specifically about testing and about the different pathologies and lesions that happen that affect the somatosensory system. So really, when we're talking about the pathologies and lesions in Chapter 7 here, it's really just an overview. We are going to talk more about it later in other chapters when we talk about those specific symptoms, but we're just kind of talking about how somatosensation can be part of the clinical picture when we have these specific lesions. So some of this is going to be a review from our tests and measures class this summer. So, and then again in neuro rehab, you're going to be doing sensation testing because that's really important for neuro rehab. You're going to have that class next quarter. So there is a ton of information, obviously, in neuro, a lot of class, but for learning purposes, the more you can connect information to what you have previously learned in other classes, the more you can integrate it and understand the concepts. And so I am going to try to help you do that by talking about some of what you've learned in previous classes. And our assignments in this module kind of bring some of that information into play. Like some of the modalities that you learned last quarter with Brenda, how does that apply to the somatosensory system? How does that apply to different pathologies? And so hopefully this can help tie a few things together. Plus it can help link this new information back to things you've already learned and get it more firmly entrenched in your mind. So the somatosensory system is really necessary for protecting us against injury and for accurate control of movements. So if we didn't have any somatosensation, we'd be going through the world, stubbing our toes on things and sticking our hand in the fire accidentally and be getting injured, and we wouldn't know it. That's not a good way to live. We probably wouldn't live very long without our somatosensory system, or it would be quite difficult. It's also that proprioceptive information, accurately controlling our movements, and getting the feedback that's necessary for our brain to provide the orders for how we're going to stay balanced and walk and do our day-to-day activities. So the somatosensation is kind of where it starts, and it's really important for all this stuff. So just kind of a little review on what we did last summer in tests and measures. When we're doing the sensory exams, they are going in the conscious relay pathways. So now we're just going to link some of that information that we learned last summer into what we're learning now. So the sensory exams, the conscious relay pathways, they're testing discriminative touch, conscious proprioception, fast pain, when you do the sharp point and all that, and discriminative temperature. Is it hot or is it cold? And the purpose of a sensory exam, we've talked about this before, is to establish whether there is sensory impairment present. And if so, what type of sensation is affected and what's the severity of the deficit. So the sensory exam uses those conscious relay pathways to test those different things and see if we have sensory impairment present. So we talked about this summer, guidelines for improving the reliability of your sensory testing. We want to administer the test in a quiet, distraction-free setting. We want to position the patient in a supported position, either seated or lying. So we're not going to challenge their balance. They're not going to be worried about that. They can concentrate on the sensory information. We want to educate the patient by explaining the purpose of the test and demonstrate each test before we administer it. we want to block the patient's vision so we know they're really using their senses, their somatosensation, not their visual sense. And we want to apply the stimuli near the center of the dermatomes being tested, because we talked about the receptive field and the overlap of the receptive field. We want to make sure that we're doing it in the optimal position. So there's a quick screening that a PT will do, testing for proprioception and vibration in the fingers and toes, and testing for fast pain sensation with a pinprick. Of course, you got to watch your infection control and make sure you're using a sterile tip. If they find loss or impairment with that quick screening, then they will perform additional testing to determine the pattern of sensory loss. So, interpreting test results as PTAs, it is outside of the scope of our practice to interpret test results. What we do is we provide the data for the PT, who then interprets those test results. So there's information in the book about interpreting test results, and it's good to know so we're getting accurate results, but that is not something that we actually do. But the overlapping of dermatomes, you can kind of the PT can use that information to locate which sensory root is involved, where complete loss of sensation is. So those test results, it's important to be accurate so the PT can interpret those test results and kind of localize the problem a little bit more. The warning or the caveat is that the patient has to have conscious awareness and cognition. So the patient has to know what's going on. You have to be able to explain it to them. So someone who isn't consciously aware or is cognitively compromised, you can test, you can touch them and see if they respond to it, but it's not really very accurate. You can do that just for, say you're applying a boot to their foot or something like that, that's going to keep them in a certain position if they're having to stay in bed, like they're in ICU in the hospital or something. But it's not accurate for sensory testing. It can be a quick thing to see if they're even detecting you. They might not, though, even if they have intact somatosensation, because their consciousness or cognition is compromised. So there is, in Chapter 7, there is a chart, and I have it in the module as well. And this is really just a review of that testing that we did in the tests and measures class last summer, how you do it, what you're testing, and we are not going to do that in this class per se. You're not going to need to know any of the testing information for the exam, but it's a good reference, and you're going to be doing more of it in Neuro Rehab Lab next quarter. So I really just put this in here so you can start to connect that information to what you have already learned. So this is just in here. You can glance at it if you want, but it's not something that you really need to study for the test. It has those videos of normal sensory exams, and I had those in the module in tests and measures. So those should look kind of familiar to you. There's the one with the Romberg testing, which is where you're testing balance with eyes closed. So you're testing the sensory component of balance by taking the vision part of it out of it. So really that page is kind of just a review. I really don't expect you to spend a lot of time studying it. It's not going to be on the test. We are going to have just a little assignment where you talk about the different tests and what neural pathways that information travels in. Super brief, not real detailed, but that's just there for you as a reference. We're going to talk now a little bit about electrodiagnostic studies. And again, these are things that we do not perform as PTs or PTAs. Either one. PTs don't perform them, PTAs don't perform them, but they are data that we get from other parts of the healthcare team that help us in our treatment with the patients. So this information, some of this will be on the test. Not in detail of how to do the test, because obviously we don't have to do that, but just what we use it for and what it evaluates. And so there are two different types of electrodiagnostic studies that we're going to talk about, and the first one is a sensory nerve conduction. And sensory nerve conduction studies only evaluate the peripheral nervous system. So what it does is it compares three numeric values it gets as a result of the test. One of them is distal latency, which is the time for depolarization evoked by the stimulus to reach the distal recording site. So basically you have a distal recording site and a proximal recording site, and you're measuring the amount of time it takes for the stimulus to reach from one to the other. They're also looking at the amplitude of the evoked potential, and that is an indicator of the number of axons that are conducting that information, and the conduction velocity. So there's a little video where, and this is like a patient education video, where they're describing what to expect in a nerve conduction study, and they also talk about an electromyograph. I've had nerve conduction studies before and EMGs done before, and it is a little bit painful. It's not horribly painful, but it's not the most pleasant experience in the whole wide world. A lot of times they do these to test for carpal tunnel, or some nerve entrapment syndromes, or neuropathy. So basically we're kind of testing the individual peripheral nerves, and we're seeing if they are responding in a normal way. So sometimes someone has the symptoms of carpal tunnel. They have that median nerve symptoms in their first, second, third fingers, and they can have numbness, tingling, some pain with it, and it happens at certain times. Like right after they get up or when they're doing certain activities. And so they will do nerve conduction studies to try to localize the lesion. Is it actually a carpal tunnel issue where the median nerve is entrapped at the carpal tunnel? Or is it at the elbow? Because that can happen. Is it at the shoulder? Or is it actually a cervical problem? Because that nerve comes all the way down from the cervical area. So those nerve conduction studies can help them localize the area of the lesion, and then that can help guide what treatment we're going to do with them. So the second electrodiagnostic study that we're going to talk about is that Somatosensory.Evoked Potentials, and they test peripheral nerves and central nervous system pathways. So what they, both of these with nerve conduction study and with Somatosensory.Evoked Potentials, they compare it with ineffective nerves in the same patient, or there are normal values that are published, and they can compare that as well. So you can say, if you're having those carpal tunnel symptoms on your right side, does your left side respond better? So they usually do test both sides. So the sensory nerve conduction studies, this just lists the three numerical values, which we already talked about. With the Somatosensory.Evoked Potentials, it's evaluating the function of the pathway from the periphery to the upper spinal cord or to the cerebral cortex. So those are those pathways that we've been talking about in Chapter 6. And they're used to verify if you have, I don't know if there's a sensory loss or not. It's very subtle. You're trying to say, really, actually, if there is a sensory loss, it locates lesions of the dorsal roots or posterior columns, and also lesions of the brainstem. So the Somatosensory.Evoked Potential is the only one that evaluates the central nervous system part of it. The sensory nerve conduction evaluates the peripheral nervous system only. So that's kind of what I want you to take away from that, is Somatosensory.Evoked Potentials is testing the CNS and the pathways and helping to locate the level of the lesion. The sensory nerve conduction studies are evaluating the peripheral nervous system, and that to some extent does help locate the lesion as well, whether it's at the carpal tunnel or the elbow or the shoulder or the neck. So it kind of helps you out. There's a video, a little 2-minute video demonstrating that evoked potential testing. So that's just something to know about. So we're going to talk about some, just very briefly, about different lesions and what somatosensory symptoms show up with those different lesions. And there are a couple videos that are very short, less than a minute, demonstrating ataxic gait and symptoms of peripheral neuropathy. Both of those you will see a lot in the clinic. The peripheral neuropathy particularly, there are lots of people with peripheral neuropathy from various causes. And so that's a nice thing to know, the symptoms. Of course, with peripheral neuropathy, our proprioception and vibration sense are limited. And so we have lost proprioception and an increased falls risk. So a lot of people get referred to PT because they had a fall. And peripheral neuropathy is often the culprit of that. And it can be caused by lots of different things. So if I can quit spazzing out on the mouse here, we're going to just talk a little bit about sensory ataxia. So we will talk about ataxia in other areas when we're talking about the cerebellum and the brainstem and the vestibular system. So there's the 3 types of ataxia that they classify are sensory, vestibular, and cerebellar. So ataxia as a symptom itself, it's incoordination that's not the result of muscle weakness. So there's some other reason why we're unable to coordinate our muscles. It could just be, just regular lack of coordination could be muscle weakness, but ataxia means you have normal muscle response, but there's incoordination for some reason. Whether you have diminished sensation, so you're unable to have the proprioceptive exchange that allows you to coordinate movements. Vestibular and cerebellar we will talk about in those respective chapters. The Romberg test, and there's a video on the Romberg test. It's used to distinguish between cerebellar ataxia and sensory ataxia. So that is just, you can file that away in your little test kit. And there are various tests that neurologists and physical therapists will use to help distinguish between different types of ataxia. So I want you to know the definition of ataxia, and we will have more and more pathologies where ataxia is a symptom. Okay, so with peripheral nerve lesions, and we will talk more about these in detail in the peripheral nerve chapter, but the word neuropathy, you will hear that a lot. It's a general term for dysfunction or pathological condition of one or more peripheral nerves. So neuropathy always refers to peripheral nerves. So you could have a severance of a peripheral nerve, and it results in lack of sensation in that nerve distribution. So on that same chart in Chapter 6, which shows the dermatome on one half of the body, it shows the peripheral nerve distribution on the other half of the body. So when you have severance of a peripheral nerve, you will get lack of sensation in a peripheral nerve distribution rather than in a dermatomal distribution. Okay, so you might have pain associated with that. And sensory changes affect motor and reflex systems. So if you have sensory changes, you can also have motor and reflex loss. Okay, so sensory loss proceeds in a particular order. When you have neuropathy for whatever reason, whether it's diabetic neuropathy or neuropathy from an injury, you usually lose the conscious proprioception and discriminative touch first. So I'll give you an example. My mother has peripheral neuropathy in both her feet, and she has diminished proprioception. Her balance isn't very good. She has to be careful when she's walking so she doesn't fall. And one day had she was traveling, and there was those tiny little locks that go on your suitcases. She had the tiny little suitcase lock, and she was coming back from a trip. She was unpacking. She took that little suitcase lock off. It fell into one of her shoes. Well, so the next day or a couple days later, she put those shoes on, and because she lacked that discriminative touch in her feet, she didn't notice that she had that little thing in her shoe. Well, by the end of the day, her feet were hurting, and she took her shoes off, and there was that little lock, and she had a red spot and almost a bruise where that little lock had been pressing all day. So people with peripheral neuropathy, they have to be really careful what's going on with their feet. It's a really good idea to have them do a foot check with a mirror and make sure they don't have any cuts or anything on their feet that's going to cause them problems later. Just that sensory loss, that loss of discriminative touch, can cause other problems. First they lose the conscious proprioception and discriminative touch. Then they lose cold sensation. They start to lose the fast pain sensation, then the heat sensation, and then the slow pain sensation. So even after you've had a lot of loss, you can still be experiencing pain in that area because that's one of the last losses. So a lot of people who have neuropathy also talk about burning pain or aching pain in their feet, and that's that heat and slow pain. And those are those A delta and those C fibers. So we lose the A beta fibers first, and then we lose the A delta and the C fibers last with peripheral nerve lesions. And we will talk much more about peripheral nerve lesions in the peripheral nerve chapter. Right now we're mostly just talking about sensory loss. So with spinal cord lesions, a lot of times it's because you've had trauma to the spinal cord, a complete or partial severing of the cord. Somebody works as a roofer, they fall off the roof, and they damage their spinal cord. That's a really common cause of spinal cord lesions. You could also have it because of a disease that compromises the function of specific areas of the spinal cord, or a virus that affects the dorsal root ganglion. So you can have an autoimmune disease, or you can have a congenital disease or a virus that's affecting that. So with spinal cord lesions, you lose sensation at 1 or 2 levels below the lesion. So say your lesion was at T8, you would lose sensation below that. So from about the bottom of your shoulder blades down. You also lose voluntary motor control, because not only do we have, even though we're talking about sensory right now, they're also the motor nerves, and they all travel through the spinal cord. And so when you transection the cord, meaning a complete spinal cord lesion, you lose sensation and motor control below the level of the lesion. So a hemisection of the cord is where just part of it is damaged. And so remember that little video that showed the cross section of the spinal cord and the different tracks running in the different areas? You are going to have loss of pain, sensation, and discriminative touch and proprioception ipsilateral to the lesion. Because remember, discriminative touch and proprioception run in those spinothalamic pathways and those the dorsal column, and so they don't cross over till they get to the medulla. So when you have a lesion that's lower in the spinal cord, you are going to lose sensory information on the same side as the lesion, because it doesn't cross over till it gets to the medulla. You will likely lose motor control on the opposite side of the lesion, because that does cross over before it gets to the medulla. So that's where that crossover comes in. Particularly with the posterior column lesions. So if someone has a partial spinal cord injury that affects the posterior column, we're going to lose all that stuff in the dorsal column. So that is that discriminative touch, the conscious proprioception, the vibration sense, you get that incoordination because you're not getting the feedback in the proprioception, that ataxia. And the person, if the lesion is above C6, because that's where your the stuff that's going, the nerves that are going out to your hand, they might not be able to recognize, they might not have that stereognosis sense and be able to recognize objects by touching them if the lesion's above C6. So some of those losses and some of those tests, you can tell, you can localize the lesion by what they can and can't do, what they can and can't sense. Okay, so there's a little, they have throughout the book the little pathology things. There's one on shingles, varicella zoster virus, which is the same virus that causes chicken pox. Once we have it, it infects our sensory root cell bodies, causing inflammation of the sensory neurons. So it's a latent virus. It stays latent in our sensory nerves until, for some reason, we don't really know why, it is reawakened, and then people have shingles, and they can have that itching or burning or tingling. They might have the skin eruption, where the redness and vesicles have the serous fluid erupting on the skin. Pain can be really severe, and it's usually limited to one dermatome. It's often in the thoracic area. So when you look at that dermatome chart, and you can also have it in the trigeminal nerve, which would be quite unpleasant. But when you look at those dermatome charts, the thoracic dermatomes, they innervate areas, cutaneous areas, in pretty small areas across the trunk, and that's where people often get shingles. We've had, it can last for, they say usually lasts for 1 to 4 weeks, but may persist longer, and you might end up with neuralgia, but usually the pain resolves, and they will treat it with pain medications. If you can get a vaccine ahead of time and not get shingles, which is good. My one clinical example is, we had a lady that was referred to us from her primary care physician, and the referral diagnosis was back pain. So she had started having some pain associated with the shingles, and it had not erupted to the skin yet. So she described the pain as going across her low back. Well, hey, that's really common, that back pain going across your low back. So the doctor sent her to physical therapy. The physical therapist, when she did the initial evaluation, which was the next day, this lady was quick on getting into PT because it was really hurting. She still didn't have any skin eruptions yet, although it was starting to get reddened in the area, and the PT noted that in her eval, that it was the reddened area. Well, the patient dismissed it as being a side effect from a heat pack. She had put the heat pack on her back because it was hurting, and she says, "Oh, I think I left it on too long, and that's why it's red." Well, by the time she saw me 2 days later, it had erupted already into shingles. The obvious look. It was right along a dermatome. It was very characteristic of it. Just to verify it, I had another therapist look at it to verify. I looked up a picture on the internet too of shingles, just to make sure I was seeing what I thought I was seeing. And we said, yep, this lady's got shingles. We sent her back to her doctor. She got the appropriate treatment. So we know that with an infected area and with skin lesions, soft tissue mobilization is contraindicated. And so that was what the plan of care originally was, because we thought it was a muscular back issue, because she wasn't having any of the other orthopedic signs with it. And so luckily, I was aware of this, I saw it, and we got her the proper treatment and the right referral. So a lot of times we're kind of the first line of defense on changes that are happening, so it's really good to be aware of these things and what you might likely see. Okay, so when we're talking about brainstem lesions, they usually cause a mix of ipsilateral and contralateral signs. Why? Because some of the nerve tracts cross over before you get to the brainstem, some cross over in the brainstem. So if they cross over in the brainstem and the brainstem lesion is below that, you're going to get ipsilateral signs. If they cross over above the lesion, you're going to get contralateral signs. So it's that crossover is important. So you might lose if the lesion's in the upper midbrain. All the sensation tracts have already crossed at the medulla, which is in the lower part, and so the sensory loss might be entirely contralateral. With the trigeminal nerve, it's you might get ipsilateral loss of sensation from the face because it's higher up in the brainstem where it branches off. And I don't really expect you to know that. I'm just trying to give you an idea of what type of sensory loss you might get. Later on, when we talk specifically about the brainstem, we'll talk more about that. So there's a little chart with the nerves and the crossovers that kind of gives you an idea about the different lesions and how it will affect the sensory loss in the body. So that's just kind of for your information. With thalamic lesions, a lot of times it's in the loss sensation in the contralateral side because the thalamus is higher than the crossover. So really this is kind of just to illustrate the crossover point. The somatosensory cortex lesions. So you have a lesion in your cortex. So that's what's interpreting the information. So all of the peripheral stuff and the spinal cord tracts are intact. But when it gets to the cortex, you can't interpret the information, and so you might have the decrease or loss of those discriminative sensations even though everything peripherally is intact. The cortex isn't there to interpret it. So even though we're sending the information, we can't receive the information because of the cortex lesion in the somatosensory cortex. So they talk about sensory extinction where you don't have you have loss of sensation when you test symmetrical body parts bilaterally, and it can be a form of unilateral neglect, which you'll often see with CVAs. The person isn't getting stimulus from one side of the body, and so they just they're not even aware of that arm being there. So it's kind of interesting. So we're going to wrap up this section, and then we're going to start talking about pain and the body's pain control systems. It's a very interesting subject, very common in wherever you work in physical therapy. You are going to be dealing with people in pain. So that will be our next subject.